Guys, today we will talk with you about complications of peptic ulcer. 5 complications, but I won't start talking not just about complication. I won't talk about all ulcer disease of gastric. And peptic ulcers are focal defects in the gastric or duodenal mucosa that extend into the submucosa or deeper. They may be acute or chronic and ultimately are caused by an imbalance between mucosal defense and acid peptic injury. Then you see a balance. You see factors of aggressive, factors of aggressive Helicobacter pylori, non-steroid anti-inflammatory drugs, pepsin, and acid. You see a factor of defense, apical resistance, cell junctions, mucose, blood flow, and bicarbonate. And there in table you see factors of repair, and we don't talk about it on the lections in hospital. But you need to remember that they are, and it is a restitution, mucoid cap, proliferation, and growth factors. Common causes of gastric disease. The two major contribution factors to the development of PUD, peptic ulcer disease, are gastrointestinal infection with Helicobacter pylori and non-steroidal anti-inflammatory drug use. Both factors contribute to the development of PUD and interact with other risk factors to promote ulcer formation. Helicobacter pylori infection associated with 40–70% of duodenal ulcers and 25–50% of gastric ulcers. The rate of Helicobacter pylori infection and therefore the development of peptic ulcer disease is decreasing. Chronic NSAID use associated with a fourfold risk of developing PUD, increases the risk for complications of PUD. Associated risk factors Helicobacter pylori and NSAID use alone do not typically cause ulcer formation. There are often additional risk factors present, such as following, that increase the probability of developing an ulcer. For example, shared risk factors for PUD, GERD, and gastritis. The factors is smoking, for example, heavy alcohol use, glucocorticoids use, caffeine, and other. Of course, it's a problem with diet, psychological factors, anxiety, stress, PTSD, post-traumatic stress disease, and of course, it is genetic factors. We talk about common factors, we talk about associated risk factors, and now we need to talk about rare cause of PUD, and you see it on the table. It's a rare causes, but you need to know about them. Structure of PUD, etiology by region. Helicobacter, status, non-known, and others. If we talk about duodenal, the most common variant that Helicobacter will lead to gastrointestinal or ulcer disease. When we talk about gastro, we need to understand that the causes 50 to 50, yeah, not 50 to 50, but if there is 20 for 80, yeah, there we need to say that it is 30 to 70. There you see endoscopy and how it looks like in endoscopy this ulcer. Pathophysiology. Under typical physiological conditions, the cells of the gastric mucosa secrete a gastric juice, an acidic fluid composed of H-chlor, pepsinogen, intrinsic factor, and mucus, which may damage the native cells of the gastrointestinal tract. Protective mechanisms, secretion of mucus and bicarbonate to form a protective barrier, prevents the gastric juices from digesting and eroding the gastric epithelial cells. Ulcer formation occurs when either the protective mechanisms are disrupted and excessive acids or pepsin are secreted. There you see a mechanism of physiological distribution. When we talk about gastric ulcers, we see Helicobacter secrete ureas, then conversion of urea to ammiake, alkalinization of acidic environment, survival of bacteria in gastric lumen, bacterial colonization and attachment to epithelial cells, then release of cytotoxins, disruption of the mucosal barrier, and damage to underlying cells. It's when we talk about gastric, and it's when we talk about Helicobacter pylori. If we talk about duodenal ulcers, the inhibitions of somatostatin secretion, grow up gastrin secretion, grow up H plus secretion, excess H plus delivery to the duodenum, direct spread of Helicobacter to the duodenum, inhibition of duodenal bicarbonate secretion, acidifications and insufficient neutralization of duodenal contents. If it mechanism when we talk about Helicobacter and ulcer of duodenum. What about NSAIDs? Inhibit COX-1 and COX-2, decrease in prostaglandin production, erosion of the gastric mucosa, decrease mucosal blood flow, inhibit mucosal cell proliferation. What about duodenum? Acid hypersecretion and acid hypersecretion, for example, like Zollinger-Ellison syndrome, and increased gastrin production, H plus secretion and parietal cells mass, and delivery of excessive acid to the duodenum. Clinical types: asymptomatic and symptomatic. When we talk about asymptomatic, up to 70% of patients with peptic ulcers don't experience symptoms. Patients who take NSAIDs are more likely to have asymptomatic ulcers and present with complications often. Clinical signs, I think that it's better because patients with clinical signs don't lead to complications. The most common symptom of PUD, it's commonly located in the epigastrate, often described as gnawing or burning, can be related to meal intake depending on the location of the ulcer. This is about pain, all about pain just. And other stated symptoms, it's belching, indigestion, gastrointestinal reflux, nausea, vomiting, bloating, abdominal fullness. There is a table with a differential diagnosis between stomach and duodenal ulcers. Stomach pain increase shortly after eating, for example 30 minutes, and patient will lose the weight. Pain is relieved with food intake, weight gain, and pain increase to 5 hours after eating. Okay, and nocturnal pain, less common, more common. Classification of complication, you see just 5 complications, yes, gastrointestinal bleeding, perforation, penetration, obstruction, and malignization. Let's talk about the most often and the most probably complication, like gastrointestinal bleeding. Is the most common. Sudden large bleeding can be life-threatening. It is associated with 5% to 10% death rate. It's very hard, very aggressive, and we need help, people. Diagnosis: typical clinical picture: melena, blood, vomit, pale skin, high pulse, low BP, frequent breathing, impaired consciousness. Clinical features of upper gastrointestinal bleeding. There you see a hematemesis. This is a vomiting blood, which may be red or coffee ground in appearance, most commonly due to bleeding in the upper gastrointestinal tract. Melena, a black tarry stool with a strong offensive odor, most commonly due to bleeding in the upper gastrointestinal tract, can also occur in the bleeding from the small bowel or the right colon. And you need to understand that hematemesis and melena is the best clinical signs of gastrointestinal bleeding. When you start talking with patient, you need first of all ask the patient he have a vomiting with blood or with something black, yeah, for example coffee, and you need ask him about stool. Have his stool with something black or maybe blood or another something, yes, and he will say that yes, black stool I have. What you should do when we talk about patient in emergency department? And first of all, you take a patient history, check pulse, breathing, electrocardiogram, make resuscitation if it need to be done, digital examination, place examination, nasogastric tube, provide upper gastrointestinal endoscopy, laboratory analysis, CBC, biochem, and coagulogram. There you see another gastrointestinal intubation. There you see a coagulogram of patient with normal, and there you see a classification of ulcer bleeding. We have, it's a forest classification, you remember it? I won't think so, and please say that you remember. And there you see any types. Yes, you can train and remember what these numbers is of classification. Is an ulcer benign or malignant? There you see a table with some locations surrounding mucosa, edge, base, and benign and malignant. And what is different? But always we need understand this is benign or malignant when we take a biopsy and see a histology searching. Treatment, resuscitation if we need fluid, always PPI or H2 inhibitors in high doses, blood transfusion, plasma transfusion, endoscopic therapy, and surgery. Endoscopic treatment is a preferred procedure for the diagnosis and treatment of an upper gastrointestinal hemorrhage because of the low complication rate and accuracy after resuscitation and stabilization of the patient. Gastric lavage is usually performed to remove blood from the stomach prior to endoscopy. The goal of endoscopic therapy is to seal the feeding vessel, and this may be accomplished in a variety of ways. The bleeding source is identified in more than 95% of patients with significant gastrointestinal hemorrhage. Photocoagulation can be achieved by use of the laser. The laser light can be focused on a bleeding point to induce rapid tissue heating. This produces a blood coagulation and tissue necrosis. Endoscopic hemostasis may be achieved with two types of laser. It's argon and YAG. The ND-YAG lasers has longer wavelengths, greater coagulation capacity, and increased perforation potential. Heat generated from high-frequency electrical current is capable of coagulating or cutting tissue. Thermal electrocoagulation is the classic treatment for bleeding during surgery and has recently been used endoscopically to treat gastrointestinal bleeding. Monopolar and multipolar endoscopic electrodes are currently available, and both must contact the mucosal surface to be effective. The heater probe is a hollow aluminum cylinder with an inner coil. The cylinder transfers heat from its end or sides to tissue when positioned perpendicularly or tangentially. This probe may be passed through the biopsy channels or larger endoscopes and positioned on bleeding lesions to produce tamponade and heat. Studies have shown the heater probe to be safe and effective for the treatment of ulcer bleeding or non-bleeding visible vessels, achieving hemostasis and significantly improving clinical outcomes. Endoscopic hemoclips have recently been developed and made their way to the scene of endoscopic therapy for peptic ulcer disease. These devices are small, 3-4 mm titanium clips that can be opened and closed while being operated through the working channel of the endoscope. They may be used to pinch off or clip a bleeding vessel. When fully deployed, they remain fastened to the vessel after the endoscope has been removed from the patient. Emerging studies have shown that hemoclips are an effective and safe method for treating certain forms of peptic ulcer disease and should be used in the appropriate setting. Radiological therapy. Angiography is a useful diagnostic and therapeutic modality in treatment of bleeding gastric and duodenal ulcers. Angiography can identify the site of bleeding in instances where endoscopy has failed to be diagnostic. It should also be considered in patients at high risk for surgical intervention. Angiographic therapy includes two different embolization techniques for the treatment of gastrointestinal bleeding, effective in 50% of causes: vasopressin intra-arterial infusions causes vasoconstrictions that results in the cessation of ulcer hemorrhage. Embolic materials such as an absorbable gelation, sponge, tissue, adhesive, or other. Occlusion device can be inserted through a catheter into area of bleeding. Potential complication of embolization therapy may include ischemia and perforation. And of course, we have some types of surgical therapy. When endoscopic hemostatic techniques are unavailable or fail to resolve bleeding or recurrent hemorrhage, surgery provides another therapeutic options. Surgery is effective in the prevention of recurrent ulceration and in excluding the presence of malignant disease. Emergent surgery has a higher mortality rate than elective surgery, and resection procedures are accompanied by higher mortality than oversewing the ulcer and selective vagotomy or vagotomy and pyloroplasty. The operative choice is related to the surgeon's experience and low recurrence rates. Recurrence rates after vagotomy and pyloroplasty are somewhat higher. Laparoscopic selective vagotomy provides an appealing alternative for a subset of ulcer patients with lower morbidity, shorter recovery time, and a shorter hospital stay. There you can see a type of operation, what we call a beard one, when we dilate this part of gaster and do anastomosis duodenogastralis. We do when we have ulcers in this place. The next type of complication, it is a perforation. Two types of perforation of the stomach and duodenum have been observed. Free perforations occur when duodenal or gastric contents spill into the abdominal cavity with peritoneal contamination by gastric, pancreatic, and biliary juice. Clinically, this produces an acute abdomen which is easily diagnosed. Contained perforation occurs when the ulcer produces a full thickness hole in the duodenum or stomach, but the omentum or other adjacent organs prevent peritoneal contamination. The most common symptom is a free air in abdomen, and you remember it, we always talk about this when we talk about X-ray. An upper gastrointestinal cirrhosis with gastrographin will confirm the clinical impression of perforation if an X-ray is negative. Perforation is a contraindication for endoscopy because air insufflation may exacerbate spillage of gastric contents or dispersed a sealed perforation. Urgent surgical therapy is recommended in patients with uncontained free perforated ulcers because spontaneous sealing is rare. In addition, gastric adenocarcinoma cannot be ruled out, and there is a greater potential for bacterial colonization. Aggressive surgical intervention helps to decrease the high mortality associated with perforating gastric ulcers. One second. Laparoscopic management of perforated peptic ulcers. You can see in this site. It's a link on YouTube, and they're very clever guys talk about all types of perforation and what we need to do. And of course, you can watch this video when in our hospital we have perforation, what we do with this perforation. The next one, it is a penetration. Is a form of perforation in which the hole leads to and the ulcer continues into adjacent organs such as the liver and pancreas. History. This is a 13-year-old boy with recurrent iron deficiency, anemia, signs age 4, managed with chronic iron supplementation. Recent recurrence of anemia is the last 6 weeks, accompanied by epigastric pain and several episodes of emesis. 2 episodes of vomiting contain blood, hematemesis. Exon. Generally when developed, the pale male. Abdomen is soft, non-tender, non-distant, without masses of organomegaly. He have a hemoglobin 9.F, hematocrit 32.7, reticulocyte count 2.6, white blood cells 6.6, platelets 570, stool guaiac positive, CRP 3.86, amylase and lipase are within normal limits. Findings: abdominal ultrasound, hyperchoic heterogeneous mass in the head of the pancreas extending along the body of the pancreas with reactive lymph nodes anterior to the pancreas head. Abdominal CT with contrast, enlarged pancreatic head with edema at the junction of the head and body and disruption anteriorly. Marked gastric wall thickening and destination with a collection of fluid along the posterior stomach wall. Differential diagnosis: gastric ulcer disease, trauma with pancreatic laceration, wall of perforation, pancreatic pseudocyst, pancreatitis. Case diagnosis: penetrating gastric ulcer into pancreas, Helicobacter pylori gastritis, diagnosed by endoscopy with biopsy. Treatment and follow-up: started on medical triple therapy and going well. 6-week follow-up, endoscopic gastrointestinal duodenum showed healing of ulcer. And if you see on there, you see that we have ulcer and we have a pancreas, and we see these cases on pancreas with ulcer. This is a stomach, this is ulcer, and this is a pancreas. You see that how it's look like on a page. Yeah, and I want from you that you remember about 3 stages of gastric penetration. First stage, when we have a hole and it was closed by another organ. Second stage, when with this organ we have a fibrosis, inflammation, and third stage, when we have some longer, some deeper um, mm, defect, injury, and and that's all. Some deeper defect in this organ. Gastric outlet obstruction. Uh, Fewer than 5% of patients develop gastric outlet obstruction from pyloric stenosis. Duodenal ulcers give rise to pyloric stenosis more often than gastric ulcers. Peptic ulcer disease may be accompanied by varying degrees of obstruction caused by inflammatory swelling of the pyloric channel or chronic scarring associated with fibrosis. Patients with gastric outlet obstruction usually have a history of nausea, vomiting, and epigastric pain of fullness. Laboratory finds may show anemia, low serum albumin, and hyperkalemic alkalosis. Radiological exam is usually diagnostic, showing a large gastric shadow with an air fluid level. An upper gastrointestinal series without valuable formation information by showing marked delay in gastric emptying and a large atonic stomach. Endoscopy is the best test for evaluating gastric outlet obstruction after decompression of the stomach for 12-24 hours. There in X-ray you see pylorostenosis, yeah, and we see a big gastro. Surgical therapy, we need delay this part of gastro, yeah, and do a period 1 resection. Surgical therapy, the goal of surgical therapy in gastric outlet obstruction is twofold. First, improvement of the obstruction, and second, treatment of the predisposing ulcer with an acid reducing procedure. Vagotomy and enterectomy with gastroduodenal drainage or truncal vagotomy with drainage are the recommended surgical procedures. Selective vagotomy with pyloroduodenal dilatation is an alternative, but recurrent obstruction rates are higher than with the other two surgeries. We do vasotomy, we do dilatation of outlet obstruction of pylorus, yes, and then we do gastroenteroanastomosis. You see the if we have some problem with this hole, yeah, we will have another hole to help people, and we of course need to do a resection of this part of gastro. The next type of complication is malignization. Gastric cancer refers to neoplasm in the stomach, including cancers of the esophagogastric junction. The incidence is declining in the United States and Europe, while it is rising in Japan and South Korea. Gastric cancer is associated with several risk factors. Consumption of foods high in nitrates, increased nicotine intake, Helicobacter pylori infection. In its early stage, the disease is often asymptomatic or accompanied by non-specific symptoms. For example, discomfort in epigastrium, postprandial fullness, or nausea. Late-stage disease may present with gastric outlet obstruction, mechanical obstruction of the pyloric canal, leading to weight loss and vomiting. Biopsy during endoscopy confirms the diagnosis. Adenocarcinomas are the most common form of gastric cancer. Treatment includes endoscopic or surgical resection. Depending on staging, chemotherapy may be indicated before or after surgery, or as a palliative therapy. Malignization signs. General signs: weight loss, chronic iron deficiency, anemia. Gastrointestinal signs: abdominal pain, early satiety, nausea or vomiting. And late-stage gastric cancer: palpable tumor in epigastric region, hepatomegaly, ascites, Virchow's nodes, left supraclavicular adenopathy located, Sister Mary Joseph node, umbilical node indication metastasis, metastasis of Krukenberg in ovarium, and some more. Don't remember. Virchow, Krukenberg, Mary Joseph, and something else. I don't remember. Sorry. Treatment: exit therapy, which may be either curative or palliative. 1 second. I can't. Yeah, the last one is metastasis of Schnitzler in Douglas cavity. Okay, treatment: exit therapy, which may be either curative or palliative, depends on staging and the type of tumor. Endoscopic resection, surgery. Perioperative chemotherapy, sometimes radiotherapy. Trastuzumab is indicated for HER2 gastric adenocarcinomas, radical gastrectomy and lymphadenectomy, resection of the laser and greater omentum, and radical lymphadenectomy. Rox and Y gastric bypass. The surgeon separated the proximal ileum from the duodenum and creates end-to-end anastomosis of the ileum with the remaining part of the stomach, gastroionostomy, or in the case of a total gastrectomy with the esophagus, esophagoionostomy. Duodenal stump is connected distally with the ileum using an end-to-side anastomosis. And alternative is a subtotal gastrectomy. There you see that we take out gaster, yes, reduce huge in duodenum, and do duodenal anastomosis, and there we do esophagoileal anastomosis. There we do a subtotal resection and do anastomosis with ileum, gastroileum, yes, and duodenal anastomosis. Thank you for your attention. That's all. And the last I have for you one case. First, who will answer in comments below the video what the diagnosis we have and what treatment we need to do for this patient, will have something positive. For example, a mark, or maybe he can he have a chance to skip a lection or skip a couple, how you want. Okay, answer what's the diagnosis and how we will treat this patient. Thank you very much for your attention. We'll see you soon.